Nice to meet you. Welcome. We'll go ahead and call the meeting to order. I have 5:05 on the 11th, and I'll turn things over to Amy to call the roll.
Dr. Krista Jones.
Here.
David Dees.
Here.
Kathy Manuel. Dr. Peterson.
Here.
Dr. Goodwin. Dr. Reichstack.
Here.
Dr. Sanders. He's here.
Just in time. We're just calling the roll. There you go. Here.
Here.
Dr. Sharman. And Beth Benich, they're not.
Thanks, Amy. We'll go ahead and move to our next agenda item, which is approval of today's agenda. So I'll entertain a motion to approve the agenda.
Move.
Thank you. Moved and seconded.
This is the amended agenda, right?
Yes, that's correct. Thank you. Any discussion about the agenda you have before you? This was amended last week. Hearing none, all those in favor?
Aye.
Anyone opposed? Any abstentions? Thank you. Your next agenda item is approval of the minutes from December 3rd. Those are items 1 to 3 in your packet. I'll entertain a motion to approve the minutes. Thank you. Moved. Do I have a second? Moved and seconded. Any discussion about the minutes? Hearing none, all those in favor?
Aye.
Anyone opposed or any abstentions? Thank you, everyone. Now I'd like to turn things over to public participation on our agenda items. Do we have any public participation on agenda items? Okay. Correspondence and communications. Julie, any additional information on things?
No. We don't know anything about cuts. We know that's a big thing, but we're still waiting.
Any questions for Julie? Thank you. Moving to other business, we do have a demonstration of the Health Atlas software by Metopia, and they are here with us, joining online. And so I will turn things over. If you would like to introduce yourselves, please.
Hi, I'm Angie Grover. I'm co-founder and COO for Metopia.
Hi everyone, I'm Nicta. I'm the Director of Customer Success for Metopia. Excited to be here.
Thank you both for joining us. And I know we have had some conversations about the nursing home and shortages, and we're looking forward to hearing some information from you. So we should be able in this room to see the slides that you have created. So we'll turn things over for your presentation.
Okay, so I was actually going to share the platform, so I should be able to do that. This is going to be a live in person rather than a set of slides, which I know as so many board meetings go, slides can be repetitive. So let's take a little journey through the Champaign-Urbana Health Atlas. So we, Metopia provides curated data and software for you to do analytics to understand your community better. We work with public health departments across the country, and so excited to support the important work that the Champaign-Urbana Public Health District does. What I'm going to touch on in the next couple minutes is some of the functionality, and really what we're trying to do is share important data with communities so that they can understand and align with some of the priorities that you're working on in your communities and dive deeper. So on the landing page, we have the ability, so I'm just going to go through some of the functionality, including the data, the places, and a couple of the insights so you can see how this works. You can jump right into a place and a topic that you care about, or explore the atlas with a typical search. This will take you into any topic or place that we have curated. I'm going to start with places first. So we have the ability to look at any place within Champaign County down to the census tract level. So this includes cities and towns as well as census tracts for data wherever it's available. So So data, I say not all data is created equal because some data is available at the county level, some is just at the zip code level, and then other data has stratification so we can understand places at a more granular level. So we curated it for you so that you can understand what this data looks like from a geospatial perspective. Before I jump into the visualizations, I'm actually going to show you the data dictionary. So we worked together with the Public Health District to identify 100 topics, about 100 topics, that are important to the work of assessing communities. These can be searched by any of these categories. You see here on the right, you can open them up and see all of the topics that we have within those. Or you can search by any of these facets. So layers, as I said, down to the census tract level. You can pick a particular place. You can look at a time period. For this data, it's really important to look at those trends over time. So, having now come out of COVID for some time period, we had a big bump there, and now we're seeing what the new normal looks like as data begins to be reported post-COVID. So having that longitudinal look can see what those differences are over time. Stratifications are important to understand disparities in different populations across the community. And then we have all of our data sources. All of these data sources are verified, curated data for you. American Community Survey is one of the most frequently used. And you can also use this search bar to look for something like income. When you tap on that, you can see that you have all those data facets. So one of the purposes of the Atlas is just to make sure that people have confidence and know where this data comes from. So it's cited to the original source here. If you did an insight with this, you could say I got it from ACX table B19013. That's the actual source. And we also include all the information for how this was curated. So you're never without the source documentation for any topic that you may use on the Atlas. We can visualize that topic. And now we get into the exciting things. Humans are very visual, so we like to see maps, charts, and tables. It helps us digest what's happening. So you can come here, you can roll over any of these zip codes. You'll see in the upper left-hand corner, you have the key, which tells you what, so the lighter topics here are, so 61866 has a median household income of $51,389 plus or minus $43.99. We come over here and it's more than double, way more than double. So it shows you the variation across the community. If you click on this eye anywhere on the platform, you're going to go back and have all of that data. So again, sources will also show up here. The sources follow you around the platform, so you're never without knowing where that data came from. There's all kinds of ways to customize this insight, so you can create a heat map, you can put assets on here. There's lots of things you can do to tell the data story that you want to tell. A lot of folks use this not only for community assessments, but for grant writing and for proposals, for research, etc. We can also look at comparisons and trends. So this will be your line chart or your bar chart. In all of our data, you will see that we do have the margins of error. That's because most of this data is survey data. So instead of like a hard count of, you may do a homeless count or some other count in your county, that's like a count of individuals at a moment in time. Most of this is survey data. So it will have that margin of error, and it's important that you look at that as you do these analyses. One of the most popular ones is a rank. So you can take any of the topics within Metopio and see highest to lowest or lowest to highest at any of the geographic layers that the data is available. So we can get down to the census tract and do the same thing. I do say that most people know their zip code, not their census tract, but that census tract, depending on where you are within the county, might be more granular information for you to work with. And then again, you have all the sources here so that you know exactly where the data comes from. On any of these visualizations, you do have the ability to download them. So you can download an image that somebody could put in a grant application or maybe a report of some kind. And then we also do provide help. So this is meant to, we are the technology that supports the work that you're doing with the data. So we have everything, I did a chart here. If you forgot how to do the chart, everything is here so that we are helping your community access the data, use the data to understand their part of the community, and then action it. So do something with that data. You can have access all of that help, and we also have a series of videos that will be on the site by the time we launch. So those will be dynamic videos to show users how to use the platform. If we go back to that beautiful page with that mural, we also do include a contact us. There's contact us here at the bottom here. Hang on, real quick. We have a contact us so that people have data questions, any of the technology challenges somebody might run into, and I will say we have these all over the country, and I'm gonna knock on wood, we have not had any bugs on our atlas yet. But if there's a technology issue, it comes straight to us. We'll inform you as our partner in this process to let you know we've got a bug that we're fixing. Like I said, we haven't had any yet, which is great. We have a great data and tech team here at Metopio. But if somebody has a question, then those will be routed to the appropriate individuals within the public health district or as identified by our partnership with you. You can also download, we also allow people, because this is publicly available data, we allow them to download it. Sometimes students, especially where you are, like to download it and use it in their models, or you use it for homework. We find that our university partners are really great users of tools like this. So you can download the data, and there's a process to do that as well. So the data is constantly updated. The other thing I will say, the data that's selected from Metopio's data dictionary is updated by our data team. We keep a religious schedule of when each one of these data sets is updated. As you know, kind of now data releases are a little bit uncertain, so we're tracking that day by day. But we also have a lot of Illinois state data in here as well. And so we curate that state and federal data so that your resources can really be focused on the local data, which they can curate and add to the atlas as they see fit. All of the data on here is de-identified aggregated data. There's no PHI or PII, which means this is data, and that was on purpose. We made that decision on purpose when we developed this tool, because we do want people to actually access it and use it for their work. So there's no security risks in that as well. We have, like I said, we have people on the back end. We do have a way to track how many people are coming to the site and what topics they're most interested in. That helps fuel some of the work that is done maybe by the public health department. We had somebody release a big report on smoking, and they saw a rush of people go to the atlas to look at the smoking topic. So it really does give you some community insight on how you're engaging and activating your community as well. So we're really excited. It's a very high level, and I know that I talk very fast. If I'm in the room, I can read your faces of whether or not you're following along a little bit better. But I'm happy to take any questions, or Robert, defer to you if there's anything additional you want me to touch on or mention as part of our partnership in getting this launched for your use in the community.
No, I think you've covered everything very well. There's
Beth, Beth has a question.
Oh, someone has a question.
Okay.
Yes.
I was wondering, I saw you have an API in there. What is your API? What are you REST? Are you?
Could you hear the question?
I'm sorry,
Angie?
What kind of
No.
API are you using?
That's a good question. I would have to, there's API instructions on here, so if you go to here, it gives you all of the information that you would need to use the API.
Eek! That gives me anxiety.
It's Cody.
And that, I mean, that's something, any of these functionalities, we can turn on and off. So if that's not something that you want on the API, again, this is all publicly available data. We're not giving anybody any data that they couldn't go to ACS and get themselves.
Except they won't, so this is very nice. And this is available for the community to use.
Yes.
Let me ask you, Julie, you initiated this contract?
Yeah, we did.
Yeah, okay, so, and what was your purpose in doing that?
Well, just basically what she said is to have so during COVID, we found out that our community loved the dashboards, the COVID dashboards, they love them. And so this is basically going to be a COVID dashboard, but with every other kind of thing that people want to look at. You can use it for reports and grant writing. We get a lot of requests from people writing grants that want different information, so somebody here would be able to help them, or we could actually talk to different agencies and say, here's how to do this.
Angie, did you want to talk about the challenge chip module real quickly?
Sure. So this underpins what we, so this is actually, the Atlas qualifies as part of the Public Health Accreditation Board certification if your department is going for that. But we also do automate the CHA, the Community Health Assessment, with this data. So it helps the individuals at the Public Health District really get all of their insights created quickly so that they can do the analysis on it and also produce a FABIC compliant report. So again, you have to submit that as a public health district once every 5 years. In the intervening years, you do a community health improvement plan. And so this data then also, in the priorities that you set with your community and the community health assessment, then go into your community health improvement plan. And what we've found from others who engage partners, a lot of times the community health improvement plan might be things around like substance use, like naloxone distribution or Narcan training, or maybe it might be supportive housing, whatever your priorities are in your community. A lot of times those are partnerships either with CBOs, community-based organizations, or other departments of government or other partners within the community. And so really having these tools helps you align the work to assess the needs in your community and then come together and do programs and bring resources into your community to address your highest priority. Those are all available and accessible to the public health district team in order to complete those reports. And we find that across our users across the country that it saves you about 86% of the time. So that really frees up your team, who might be stretched a little bit, to go into the community and do more community engagement, because the data is all here at their fingertips.
Is that going to help Kathy's work?
Oh, yeah.
It is, I'm just thinking about how it
Yeah.
went.
Yeah, that's why
And-
I brought
and a
the
lot of
meeting, I think
places.
it'll be helpful.
Yeah.
But like what we have in our iPlan will be able to be, that's what our community chip and CHA are.
Yes.
So, but it'll be able to be tracked on here. You can pull dashboards, they'll be going onto our website. He wants to put those up there so people can track along with how we're doing it as a community on these measures.
And you know, we were just been talking to both of the cities about the SNF stuff, and they're all engaged in their planning processes now. I mean, I think they would be very happy to have access to some of this data.
Absolutely. We find that we're actually in some communities doing the con plan for housing and urban development, or the underpinning some of the planning that goes on around transportation. So, I mean, all of that really underpins a healthy and vibrant community. It's not just health data, it's what are the other barriers to actually being healthier, and that, you know, spans things like transportation, housing, you know, food security, a whole bunch of issues that touch a lot of different parts of the government structure that you have in your community.
Yes, Bethany?
If we have a data source like from the university that we might want to share with you, how would we go about doing that?
So I would suggest that you reach out to Robert or whoever is managing this, because there is the ability to upload data from a local perspective. Will empower your team to be able to do that, so they can work with you to do that.
Are there additional questions?
Well, I got one question. I mean, I'll take a look at this, but is there ability to do actually like statistical analysis? You know, there's like with your data there, like using the GIS.
But what kind of analysis? I'm
Like
sorry.
statistical analysis in terms of the
Yeah.
GIS data, like on your own platform.
Yeah, so let me go back to, so we do have the ability to do, so the maps and charts give you the bar graphs and the line charts. We do have the ability, we do have a scatter plot function that I think we've made available to the public health team. That is not available forward facing for the community. That's a regression tool with guardrails so that you can look for correlations within the data. So I don't know if that's exactly the kind of analysis that you're doing, but we do have those abilities. And in the automation for the community health assessment, We do run a benchmarking, so we have a tool that provides benchmarking across the entire country. So if you're looking at a zip code or you're looking at the county, we can tell you where it stands out in the top 10% of any topic that we curate, or the bottom 10%. That helps, I think, people kind of gut check what they understand about the community, especially as it's compared to others across the country. So I'm not sure what statistical analysis. The map is really functional, and I'll just do this really quick, but like you can add another topic. We have household income here. Let me look for, let's just do cigarette smoking rate. So with the cigarette smoking rate, I can say, let's look at where the cigarette smoking rate is above the median. You should have seen the map kind of narrow in. If I click on any of these places, I can now see that the median household income in 61875 is 119,000 plus or minus 20, but that cigarette smoking is 14%. So this helps you put multiple factors on a map, as well as you can add assets here. So you could add, maybe we want the federally qualified health centers, because they're going to help us do outreach for smoking. So you can put assets on your map as well. So it really does give you that statistical analysis from where things co-occur, as well as the assets that overlay it. There's a lot of other analysis you can do, and those are the type of analyses we do in the automating of the community health assessment. Does that answer your question?
Yeah, I get it. Yeah, thank you.
If you're looking for the actual data to manipulate yourself, you can go into the sources. They almost all have a place where you can download it.
Oh, yeah. No, I mean, like,
Yeah.
with the ArcGIS, if you were gonna do that kind of analysis, or there's other sort of platforms, but I was just curious. It's very cool, and this is it seems to be a user-friendly way of getting
Yes.
the data, instead of going on data.gov and all these other sites and trying to do it yourself.
Yes, and our mapping does pretty much mirror what you can do on ArcGIS. It's just with the topics that we've curated here for folks to use. So really we're providing those tools on a curated set of data.
So are you just providing a pass-through to the data, or are you hosting it elsewhere other than pulling it from, so that you can cache it so that responsivity is a little faster maybe? Or if that data disappears, do you have a backup or copies or?
Yeah. Yes, we have our own database that we keep and curate all the data, as well as update it. We do quality control, because again, this is all de-identified aggregated data. So we have copies of that, and then the software reaches in and pulls that out as people are querying the data. So it is quite fast. We are also always looking to innovate and make things faster and better. But we, right now, as far as I know, we are the leader in terms of providing this kind of data interaction for communities. A lot of people can put up dashboards and things like that, but the community can't go look at the zip code that they live in, or in a group of zip codes, or get something at the census tract level, because it's buried in a lot of different tools or websites, etc. So the idea is to be able to bring these different variables together to understand how they interact.
I did have one question. So a lot of what the public health department does and the county health department does is work from a regional standpoint. So there are multiple counties that might be involved on several of the grants. I realize this is probably a strict contractual relationship between Champaign County and Atlas, but is there a way to create or get data on, let's say, Vermilion County or Douglas or others? Do you have access to that if that would serve the needs of the health department if they're working on a particular regional grant, for example?
Yes, so we define the scope by geography. We can put benchmarks into the atlas, so if we wanted to benchmark to one of our neighbor counties, we could do that. Metopio's database is national, so I have all of this data wherever it's available at the county, zip code, and census tract level. So in a lot of communities, we do multi-jurisdictional analysis. If that's something that you need to do, we would talk more with the public health department about what that would look like, but we have all of that data, just like I'm showing you here, across the country for communities across the country.
Yeah, no, I appreciate that. There are a lot of mobile services going over Vermilion County and other kinds of things that I could see where that might be important for, you know, grants or some additional kind of funding sources, which are possibly
Yeah.
so.
We
It's
use
good that that
Vermillion
actually
County as
exists.
our pretest. Or our,
Good to know.
as our control.
All right. Are there any other questions? Well, thank you very much for this presentation. We really appreciate it. It's been very informative.
Thanks, AJ and McDonough.
Thank you. Yep, very excited to support the important work you do. Thanks so much for having us.
Thank you. Have a good
Thank you
evening.
soon.
Thank you so much. Arlene.
I have a question after them, but I wonder what the cost is.
Oh, yeah. Robert, what's the cost?
So it's about $15,000 annually for a 3-year contract. There's more for the startup cost, but for years 2 and 3, it's about $50,000 a year.
It's a nice resource. I mean, can you find this all for free? Yeah.
Yeah, but
There are
it's,
multiple
it's,
programs, but.
but
it
it's
can
super
time-
hard to do.
Exactly, it's
Right.
very time consuming
Very,
and
very
this makes it very
time-consuming.
user friendly, and then you can always do, if you wanna actually go do more of the analysis, you can always bring it to a more robust system, but it's like, I like it.
Yeah, I mean, you have to get into some programs to cross paths like that though.
Yeah,
Right.
yeah.
Rob will have to start going out and doing little dog and pony shows of all the different agencies so that that knows, you know, so that they can use it if they want to use it.
Did she say something about it launching? Is it, has it launched or is it about to launch? What's the timing on that?
So the plan is to embed it on our website. We haven't gotten that far yet. I think the link is live, so anybody can access it if they have the URL. We just haven't put it on our website yet, which we will do soon.
When would you expect to roll it out?
I don't think it would take us very long. We could do it tomorrow. I could talk with our IT department and see if they could do that for us.
But probably by the end of the month. then for
Yeah.
sure.
Yeah, definitely.
That's an URL tonight.
Yes.
To give you the,
Right.
There was a question, Robert, if that could be, if that VRL, excuse me, could be submitted to all of us and people could have an opportunity to go look at that.
Yeah, absolutely.
Terrific. Thank you very much for your presentation.
I love things I can fiddle around with, but not screw up.
That's
right.
That's important.
I like to be able to doodle around, but I
Not
can't
a
get it.
playground.
Like what Beth asked to see, I don't ever want to see that on my screen. If that pops up, I have to run in and get IT to come and deal with that. It's like about struck out.
Thank you so much for that. I'm moving to our second item underneath other business. I asked to place this on here. I'm wondering if everyone may be available in June on June 10th as opposed to the 17th. I have since learned that I have to be out of the area on the 17th, so I just wanted to see if that was possible on everyone's schedule. And so we can give appropriate notice to all of the individuals that need to know. So I got a thumbs up from.
I'm looking at it.
Oh, okay, awesome. Everybody check your schedules and see if June 10th works. Oh, that's right, you're off the whole month of June. Okay.
I'll be on paternity leave then, but
Nice.
I may still
Yeah.
make it.
Well, we
How is your
could
pregnancy
do
going?
online, as long as we have a quorum hearing, we would probably love to see. So that would be like a double bonus.
Educated.
Okay, Dr. Pearson?
I'm okay.
Dr. Bethany, what do you think? Oh, you're still looking,
I think so.
Kathy?
I have to check and see if I'm actually going to the summit.
Oh, you could do remote
Is there any
Yeah.
conferences in?
I think as long as we have a quorum, we can do a few members remotely, as I understand from our last conversation with Julie
Are you
Reeves.
going to the DHO?
Oh, is that during a conference?
No, I was just asking, because, you know,
There's the Public Health Institute's conference, but I don't know if anybody's going to
on
that.
June 10th? That's fine, I like it.
Are you going?
I don't know.
I'm not.
Is it Minneapolis one?
Yeah.
I was planning on it, but it's not like, surprise, when did you consider?
June date. I'll be back from Maryland on the 31st, I could also do June 3rd. I thought if we go farther, it'll be like vacation time for most people, I thought, right? Yeah. Yeah.
Third is good too for me.
I could do the 3rd. I'll be back.
I can do
You can't do the 3rd?
No, I can't.
I'm not too sure, I didn't know what that was.
Okay, gotcha.
The 10th is fine. I don't know if I'm
Are you sure?
going, and if I am, then somebody will sit in. Candy's looking like she wants to be the one to sit in there.
I'm sorry.
You
You were voluntold. Yeah, you were voluntold.
Okay, sure, you can do it.
Okay, so you're okay with the 10th then, if we do the 10th? You sure? Okay. All right, if everybody's in agreement, then I'm just gonna switch the date from the 17th to the 10th. And that's not nice, wait, you can turn it over for a minute, we can see what's going on. That sounds awesome.
Expected May 25th.
Oh, congratulations. Oh, is that your birthday?
Yeah.
That's small world. I like it.
Another Gemini.
The world needs more, right? That is very exciting, congratulations. Okay, Smile Healthy, and I think we've got some representation. So monthly reports for November, December, and January of 2025. So I will entertain a motion. You've got those reports there, so I entertain a motion to file those reports. Move the second, and then I can open up for new discussion. So moved, and do I have a second?
I second.
Okay, moved and seconded. Any discussion on those reports?
But once again, I do appreciate the narrative.
Yeah.
And I'm glad that you got to pedal, or you're gonna forget about the pedal to the portable exam chair. That's granular reading, I mean, you had to read it down there to get that.
Well, I'm glad you read it.
Any other comments or discussion?
Yes, I just have a question about whether or not they could comment on the impact of federal funding, especially like on some of the Head Start stuff, and whether or not, as a federally qualified health center, they expect that to impact them.
Feel free, you can, if you want. Anybody else?
I've worked in federally qualified health centers for 24 years now, and that is an ongoing concern every year. I think this year is kind of unique just because of the leadership changes that have occurred. So I think we're all on pins and needles, not just Promise Healthcare, but every FQHC.
You haven't gotten any direction or any communication that tells you that there are certain cuts?
Well, we know that at the end of this week, they're supposed to balance the budget.
Yeah.
There's some discussion about pushing that out until September. But I think it's just an educated guess in terms of what the outcome might be. We have been very fortunate in the sense that we've been able to draw down, and so those pauses did not affect us locally. But there are some agencies in other states that it has affected.
But you haven't been told to reduce staff or anything like that?
No. I think we continue to try to be a little bit more innovative. Specifically, my stewardship is over dental and the facilities and expansion. So one of the things that we're looking at is optimizing the skill set of the disciplines that we have. We've recently, in the last few months, been really focusing on the public health dental hygiene program as well as the expanded function dental assistant and optimizing them to help our dentists see more patients and ultimately increase the care, whether it's oral polishing or fluoride or SDF applications. So just try to be smarter with the staff that we have and be more efficient. So until we're told otherwise, we're going to continue plugging forward.
And you haven't heard anything, I know you have the enhanced Medicaid reimbursement, you haven't heard anything about that being reduced at this point?
Yeah, so the BPS rate definitely is something that's always been on the chopping block. We are also moving towards the 340B, the enhanced payment through the pharmaceutical, our expansion into the pharmacy. So a lot of dicey moments in months to come, but I think we just optimistically go forward and plan for the best and prepare for the rock and roll ahead of us.
Okay, thanks.
And I think I can tell them what we've got kind of going about the East Wing.
I would love for you to mention
Hey,
that.
have I talked to you guys about that yet? Go ahead.
No, I'm sorry, I thought you were talking to me.
I was. It's something that Jennifer, we've been still working on with maternal and child health and families division and stuff. We're looking at having Promise move into the East Wing in the clinic where Avicenna is, because they're still 3 hours of service a week. So they can still continue to do that on the Sunday, but they're looking at having something here in our building down there. It'll be in the immigrant cooperative, it's already built, and it will have like services for the families that come in here for WIC mostly, and the family dental. It'll just be another FQHC. This group is moving out July 31st because we need the space, and then moving them into the basement, and that'll be really nice. And they're gonna have a pharmacy and everything, so.
Wow.
I know. And when she told me you were getting the pharmacy, I was like, oh, that's exciting. That's important. And that way we will keep working to coordinate our services so that we're not duplicating anything. So we're working on things to try to, and that's the main thing. So that'll be exciting. And we need more prenatal care. We need more prenatal care. Candy will talk to you a little bit probably about what's going on in her division and a little bit, specifically the syphilis thing. Bring that up. Okay.
Thank you. Any additional questions on the monthly reports? So we've got motions been moved and seconded. All those in favor?
Aye.
Anyone opposed or any abstentions? Thank you. Now I draw your attention to items 10, 11, and 12. These are the approval of the invoices for the Champaign County Administrative Services for the Child Dental Access Program for November, December, and January. So I would entertain a motion to do those collectively unless anyone wants to separate them. Do I have a second? Moved and seconded. Any discussion on those invoices? Yes, ma'am.
On the December report, it's a dated invoice February, but it's different a little bit than the other 2 months. And it looked like the biggest difference was the administrative services. It says strengthening Illinois public health and admin contributions and grants, and it was about $28,000 for that. I just wondered what it was. Yeah. So it's here, and the rest of them are.
Oh, that's a SIPA grant, so that's a workforce development grant that we got that goes, you want to tell them what it is? SIPA grant?
Yeah, the SIPR grant is it's called the Strengthening Illinois Public Administration Grant, and we use that for training. It's actually covered the startup costs from Metopio, the cost for the first year. We also use that for bonus retention. The bonus retention policy here is the Champaign-Urbana Public Health District, and
It pays out in December.
it pays out in
Yeah,
December.
all the bonuses are paid in December.
Right.
So this would be mostly for this particular month, it wouldn't be recurring.
Yes.
Right, is it that grant over?
Every year, the bonuses are paid at Christmas, right around Christmas.
So it would show up every year in December.
Yes, in December. They won't be paid at any other time of year.
I think that's, grant period is through November of 2028.
Are there any other questions on the Promise Healthcare Administrative Services for items 10, 11, and 12? Hearing none, all those in favor?
Aye.
Anyone opposed or any abstentions? The next item is underneath CUPHD, 13, 14, and 15, the CUPHD invoices for October, November, and December, which was just to Kathy's question on that. So are there any additional questions on that or any further discussion on that? We'll start with an approval first to move those together for October, November, and December. And do I have a second? Moved and seconded. Any discussion? Hearing none, all those in favor?
Aye.
Anyone opposed? Or any abstentions? Thank you. That moves us to approval of the updated retail food program ordinance. And so, Sarah, you're gonna speak about
this was our discussion in our last meeting, introducing the placard ordinance for the county. The discussion, they didn't want to have a separate ordinance for the placards. They wanted to actually include it in the existing retail policy, our retail food program policy. And so that'll be under section 5 of our existing, so we're just basically updating that.
That was a decision made by the county executive?
Yes.
The placard had been mentioned in there previously as a form of recommendation and not it was a may or shall. So we're trying to turn that. So there's already space for it.
Okay, because the history of this is that
Yes.
the placard portion of the ordinance was denied by the previous county board.
There is a mention of it, it is just more of a gentle suggestion.
A gentle suggestion.
It's
Now it's not so gentle.
Yeah.
So, I brought this up last time and I still don't understand it. You are referencing a December 3rd, 2018. And it seems that really ought to be updated.
It will be updated
That's,
once that section 5
yes.
is added. So they are wanting to take, right now it's a separate placard ordinance for CUPHD. They actually want to include that into that ordinance instead of having a separate one. So that would, basically the language from that ordinance is put into section 5 and it will be updated.
So is this a typo then? It's under a section 7 authority. This ordinance shall be published in pamphlet form not later than December 3rd, 2018. We're a little behind on that one.
That's correct.
That would be needing updated.
Yeah, that would have to be updated once this is passed. So then I'll have to put it in pamphlet form and do more education as far as once we start doing inspection for the placards to follow.
Okay, thank you.
And is everyone familiar, I don't want to make any assumptions what we're talking about with placards, does anyone need to have any
The
conversation?
green thing is you walk in the restaurant.
Green, yellow, or red. That's correct.
Hopefully,
That's correct.
Hopefully the green thing.
There are very few red ones. There just are.
Yeah, one of them made the paper, however.
Well, and we'll be
Well, you know-
we will be in court tomorrow
Yes.
regarding that.
Oh.
'Cause
It was interesting, the commentary on some of that was that we wished we had that placard ordinance in the county. So that was actually brought up by 2 consumers
Mhm.
on the
Oh.
comments.
Good.
Of course, they're
Okay.
gone now, but they were there.
Yeah, and all the comments are gone now, but, yeah, but that was something that originated in this body, right here, and it was passed, and then we went and got it passed at the district,
Yep.
and then when it went to the county, it didn't pass, so we were in this kind of like, oh, that's weird, so, anyway.
But it would be a huge benefit as far as enforcement in the county for this type of thing.
It was greeted with the same incredulousness that you guys are showing now to the current board, but we did not have that countywide. It is very popular.
Very popular? Is that what you said?
There is, I would be very surprised if there is more than maybe 1 or 2 votes.
And I've been asked, occasionally by the cities, if, do you really need that thing? And I said, well, I don't think we need it, but it is, of all the things we've done, it is wildly popular. Way more than we would have ever thought. And, people think that we send these press releases out. We do not. We never send a press release out. None of that information gets out, nor do we talk about a restaurant that's, doing stuff. But right, but they're on our website, and they're out there for a reason, because we're getting quoted every single time. So this way, they're out there, and the media, if they get on there and want to do something with them, they do, and if they don't, they don't. But anyone can look that up, and you can scan it when you're at the restaurant if you want. I did with my gas station mac and cheese I had before this meeting. I didn't scan any of Like I could have.
I have a green flag.
I wish I wasn't serious, but I wish I did.
Good clarifying.
My condolences for your night.
I gotta get all that out of me before the toilet paper shortage hits. Gas station eating.
Thank you for that update. Any additional questions for Sarah?
Do we need to, make a motion to amend the amendment before we approve it with the date change, or is that more the?
We will, I had, with the email, I told her that needed, I agreed with her dates that she had come up with, but they hadn't changed. I thought we'd have an updated,
I would just pencil it in so that we can make sure all our eyes are dotted. So I will formally move to a friendly amendment to the ordinance to make sure that the date is commensurate with reality.
Consistent with reality.
because they said this would move forward at the next April meeting.
Yeah, that's wait till the next
And
meeting.
that's correct, and so once you guys, send it forward, then they would correct the dates, I'm guessing. I would-
Well, no, because we have to vote for it. As we vote for it, that's how they get it. So if they amend it, they gotta send it back now. You don't want to be doing it all back now. So just, I would just,
Just change the date.
yeah.
And I think it was April 23rd is the
It
date.
was in the email, there was some date.
Yeah. I don't remember if that's correct.
Make sure that
April 25th.
there it is. I will, motion to change whatever the 28th date is to April 25th.
And one would take effect, full force and effective after. Here is January 1st, 2019.
It'll be after that. It'll be the day after.
Definitely after 2019.
No, after the,
We're covered on that one.
let's not go backwards.
Would you make it like, when is the county's fiscal year?
December. It would probably be.
December, before that.
If you want,
So January 1, 2026?
I would say, yeah. Because you need people to be kind of like, plan everything out.
I can have that done the next day.
If,
That's-
hey, if, you know, if you
Yeah,
want to
I'm-
put it out there.
Yeah, I can already work on the pamphlet, that'll be done, but
If you want to name a date, go for it. August 1st?
I'm fine with the day after the meeting,
All right.
so.
You probably should, it's gonna be, it's April 25th,
Yep,
right?
that's
So
what we're
you'd
gonna
be looking at either May or June.
Yeah.
May 1st or June 1st. June 1st is a nice number.
Yeah, I would say June 1st,
Yeah.
just in case.
Now, Sarah, they already have the placards, correct? It's not like you guys are gonna have to run out there and give them all placards. They have them. They just have no mandate, they have no mandate.
Right now, the system is voluntary.
Right.
So once we start, once we pick a date, moving forward, when we have an inspection, they'll be issued a placard. So we're not gonna be out there issuing those until their next routine inspection.
Okay. But if their next routine inspection is like in December and, you know.
Yeah. then it would-
And they chuck that thing in the trash because it isn't, you know, necessary to put it up there, does that mean they pay $5 fee to give it a kind of copy, or is that?
The placard is actually property of the jurisdiction, so it'd be property of the Champaign County Health Department, so they can't remove that.
No,
So
but I'm saying.
the $5 replacement is for your permit,
Okay.
so we would just have to educate them. And put the placard back up on the wall.
So, but you're gonna wanna put a date down, so make
That's what I'm saying.
it June 1st.
June 1st.
And I've corrected those dates on the document here. So we are looking for a motion then to approve the Champaign County Public Health Department recommended retail food ordinance program. Moved, do I have a second? Moved and seconded. Any further discussion? Hearing none, all those in favor? Aye. Anyone opposed or any abstentions? And I'm gonna pass this over to you because I've signed it, you need to sign as well, Kathy.
Excuse me, I have to.
Yeah,
Thanks, David.
I have to-
Our next agenda item is a report from Team Health Services.
okay if I hold up the table for a minute?
Go wherever you like.
All right, so I did write up something. I know Dr. Peterson loves the write-up. I'm Keeney Krause. I'm the Director of Teen and Adult Services here at the district. I've been with CPC since 1999. So I appreciate the invitation to.
Is it your old?
Well,
We're
you
older.
were.
We've been here.
I was going to say you were here before I was. I believe you hired me. I appreciate the opportunity to talk to you about our division services. We are a multidisciplinary team. We have nurses and care coordinators. We used to call those case managers. They're care coordinators, and some intake clerical folks that work with us in the division. All of our services are anchored around a comprehensive clinic that is in our facility. We have 8 exam rooms that surround a moderately complex lab. So we have the capacity to do some on-site testing and resulting. And we have a lab tech that works with us on that. I have 2 nurse practitioners who work 4-day work weeks, and so there's some overlap in addition to our medical director, Dr. Ann Robin, who's with us one afternoon a week. In addition to the clinic, we have a lot of outreach services that come out of our division. We're on site over at U of I with the prep clinic once a week. We're at Rosecrans at least monthly. We're at the adult jail monthly or weekly. We're at the juvenile detention center, so we're all over the community. Plus, we do door-to-door outreach with some of our harm reduction and Narcan services. One of the things I wanted to highlight for you is we have a partnership with Maternal and Child Health here and Solio Gratis. Gradia, who's a farmer, a food co-op in town, and they have a free Friday market over in southeast Urbana. And so all the services that MCH and Teen and Adult provide are on site, in addition to free food, which is a great way to get the community to come see us. And we're going to be expanding that initiative this year. We're adding a location at Washington Square, just north of downtown, and then the Haven, which is a new development out behind Walmart. So we work with the Housing Authority on that outreach. We do special event testing and outreach around World AIDS Day and National HIV Testing Day, some of those high holy days in the HIV world. We started HIV testing actually in the late 80s, 1980s. Our predecessor, Joe Lathrop, was involved with that, and the CPHD HIV testing site number is 004. So we were the 4th site in the state to start. And then we started Ryan White Care Services in the early 90s. It was 93 that we've been. So we've been involved in HIV work for a really long time. Our HIV testing mostly focuses on folks that are most at risk. So many of us work with other persons who have HIV positive partners, and maybe their partners are not virally suppressed. So those are the folks that we work with for testing. Our staff has been really involved with the Getting to Zero initiative in the state. For those of you who haven't heard of it, it's a 2-pronged approach to reduce the number of new infections, and we do that primarily through PrEP, pre-exposure prophylaxis. And the other tenet is helping those persons living with HIV achieve viral suppression if they're able. And so with those 2 things, where it's actually working. It's actually working. New incidents in the state has gone down. And so we'll see what happens with funding.
Not
So
to
which is
interrupt you,
why-
Candy,
why the
but
federal
is that going to
government-
be affected?
Yes.
Yeah. Will it be affected? I don't know. A lot of the money that we get for PrEP, it comes through a state grant. Potentially, that could be affected, but the actual service itself is paid. Insurance and Medicaid pay for the medication for PrEP. So we'll see.
We're not going to suffer.
Ryan White, HIV funding has had a pretty healthy support, and I'm not sure what's going to happen with Ryan White funding. We thought Ryan White funding was going to go away when they started the Affordable Care Act, because that was part of the big chunk of money that was going to pay for that. Because in theory, if everyone has health insurance and has a primary medical provider, they don't need us doing any of it, but we know that didn't happen. And then so PrEP, I know that was one of the topics that Julie asked me to talk about today. It happens to be my favorite topic to talk about. Pre-exposure prophylaxis is a medication that is provided to persons who are HIV negative. There's an oral form of PrEP taken every day, and there's also an injectable PrEP, which is like, you know, Depo-Provera now, where a person can take the injection every 2 months. That was an initiative. The injectable started, I believe, almost 2 years ago now, and so we offer both of those options for our clients. In calendar year 24, we saw 200 individuals through our PrEP clinic, which is crazy to me. I never imagined we would go over 100. We're kind of a small community, and I never imagined we would see more than 100. So we're seeing 200 individuals, and that's for anybody who may be at risk for HIV. So the CDC expanded the definition, so it's not just our gay men or persons who have a positive partner, but anybody who's potentially at risk. So we have a family planning clinic as well, and some of those individuals have taken advantage of PrEP. Let's see. One of the other initiatives that we work on with between HIV prevention and care is a Data to Care initiative. And that actually looks at persons who are living with HIV who have not seen a medical provider for their HIV care in the last year. They let us know, and we do what we can to find them and engage them in medical care. So that's some of the work that my staff do.
Can you imagine having that for diabetes or something? How much that would
Yeah,
cost?
that'd be incredible.
It would be-
Yeah.
Right?
There's so many conditions. Yeah.
It's,
Oh, of course.
it's the model that should be used, but, you know, we don't, we don't value that.
Yeah. We do engage our clients both in PrEP and Ryan White services and insurance coverage. So we have staff that are trained to do Medicaid enrollment as well as marketplace engagement. So we're very active in that. In our STI clinic, we saw just over 1,300 persons last year for our service. That would include folks that came back to us for treatment. We do a treat and test model, which means that a person comes in and it looks like they have gonorrhea, chlamydia. We go ahead and do the treatment and then follow up with the testing. And generally they're pretty right. But and then we also provide syphilis testing and treatment. And was there something specifically you wanted to talk
Stuff
about?
about congenital syphilis.
Congenital syphilis, as you know, is on the rise in the States. It's been going up since 2019. COVID didn't do us any favors with the introduction of traditional medical services for folks. And so what we've seen is that in Champaign County, we had a congenital syphilis case once in a while. Once every few years, we'd see. We had 2 last year. And these are highly preventable situations. In both cases, in one case, the mother was inadequately treated and gave birth, and so the baby spent 10 days in NICU, completely avoidable situation. And the other situation was a person who wasn't engaged in medical prior to giving birth. So what we're doing here to help get the word out about syphilis is testing. So we get a lot of folks come in for pregnancy testing, for Medicaid enrollment, and we're doing point of care syphilis testing at the time of the visit, positive or negative for pregnancy. So trying to engage that population and taking, syphilis is very easy to treat if it's caught.
How is it being treated these days? It's no longer the high-dose penicillin?
There's still high-dose penicillin.
It's never going to change.
Yeah.
It's never going to change.
And there is an oral. I'm not, I'm not a doctor, so don't put me on the spot what the oral medication is. But there is an oral antibiotic option for, but it's limited use.
So high-dose,
Yeah.
multiple doses or the same?
So the algorithm is extremely complicated. And I won't be able to, off the top of my head, tell you about it because our APRNs in the nursery, we stole from Krista.
or at least one of them. They largely handle that, but I will say one of our challenges is getting the information from our OB/GYN partners that what has already been done and if it's been done correctly, and then we know what to do with the baby. So it is a challenge because it is so complicated, and many times we have to call pediatric infectious disease specialist. Not always, it's just in the more ambiguous cases. And we go by like titers and all of that stuff about what path we take. Many times you only need the one dose, but sometimes we have to do the 10-day course.
Illinois does have a syphilis warm line now for the physicians to contact. I have heard good things about them, but I've not called them. So
Yeah, they're very
that's an
helpful.
option. Good, but I will also, I'll reach out to you, one of my staff member. Literally, she's the one that handles all the syphilis cases in town. I'll be happy to put you in contact.
Yes, please do.
We're doing everything we can to get in touch with you all, so this will be fantastic. So it's, the focus has been in the last year and a half or so on syphilis. And with the point of care testing, that's really helped our efforts because we went to blood draw. So, let's see, we, disease intervention specialist, which is what we're talking about, the folks that actually make sure that that person's adequately treated for an STI. That's actually something that for the last 10 years has been in the public health world as something that they're working on certification for. I know I was involved with groups back in 2016 and 17, actually trying to figure out how we're going to test folks. So, because that would include not just STIs, but TB, and anybody that's doing this disease investigation work. And so they, it can become a billable service, and that's the goal. But this is, we're all trying to get off the grant funding, so that they stop as one of their jobs.
Why would that be?
Right? All right, I mentioned that we have a reproductive health clinic. We received Title X funding for that, and we started that clinic in 2013 when Planned Parenthood stopped taking that grant money, and so Julie got us involved with reproductive health. The other big project that comes out of teen and adult is our harm reduction and Narcan distribution. We do comprehensive harm reduction services, so syringes, waters, cookers, the whole nine to encourage folks to, at this point, it's not even HIV prevention, it's Hep C prevention, hepatitis C prevention. HIV has been virtually moved out of that population in our state because of syringe exchanges that have been around for so long. We have a very, very small number of folks that are infected that way.
And in case you don't know, we've been doing it here for
2001.
Yeah. And
We've had dedicated services since 2005.
Wow, so you guys have been like providing the needles.
we've been
That's
doing
great
it
since
before it was legal.
Right, yeah.
Because we were able to use
Out of Chicago, right?
exemption
You were able
loophole.
to piggyback Chicago.
We still do.
We
Same
still do?
thing,
We still do.
yep. That's who got us the exemption.
The laws that have changed are for our residents who are allowed to now carry syringes. The exemptions haven't changed for departments to give out syringes. We're still
Oh,
working
really?
with every syringe exemption. Yeah. But it works. It works,
Yeah.
so we'll take it. So syringe exchange is a big part of what we do during COVID. We set up a contactless supply pickup on the backside of the building. We named it, for Dr. P, we named it Beth. You would appreciate that.
You remember Beth Wehrman, the needle lady that?
Yeah.
From Philosophy. So a lot of our supplies are actually picked up contactless on evenings and weekends. And then the Narcan distribution, we've been involved with Narcan distribution since 2010. But in about 2018, we started a regional project where we're actually working with our other health departments in the region to encourage them to do the same things we're doing, and we supply them with all the stuff they need to do, including Narcan, and encourage them to get it out into their communities.
Is funding in danger for that?
It's been discussed as potential. there's the opiate settlement money,
Okay.
which I don't know, I guess they could take, but I don't know, that would be harder to take in my opinion. But the money that we get from HHS for Narcan distribution is definitely on the discussion.
And I think for that, that's something we can go back to the county board with, because we gave our recommendations, as you remember, last year on the opiate settlement money. And I think they're gonna put a few of those in play, but if this ends up happening, then that would be good to let us know, so then we can talk about, maybe we can go back and say, maybe we need to make some reallocations of that money. I know law enforcement also provided a pinch, and a couple of other organizations, but. you know,
Officers are carrying Narcan.
Yeah,
Yeah.
yeah, our officers have been, it was a slow uptake, but we don't work with EMS or police or fire in the district much at all, and in the county, there's a few places, and our county's done a really good job with this.
How many, about 40 reversals, every year, or is it
Oh,
more than
gosh,
that?
it's gotta be more than
More than
that. And that's the problem with reporting reversals is we don't know. Narcan has become so
There are
common.
dispensaries here.
Yeah, so common that we don't know. I mean, I don't think that people are thinking about it anymore. You know, and so, you know, I think for the folks that we're giving it to, like, that are using drugs, I don't think we're hearing much about it at all, unless we ask specifically, and it was traumatic, I don't think we hear about it. So I think we're having a lot of reversals.
Does EMS like give you that data?
EMS, we do have data from EMS, they report into the state system.
The hospital emergency rooms, do they?
They do.
Do.
Oh, okay.
So you don't know what's happening on the street?
That's correct. I think.
Which is probably where the most are happening.
I think that most of the reversals don't hit. I think that most of the reversals are happening in somebody's house, and they don't hit the EMS or the emergency room.
Even though when they get it, they're encouraged to go ahead and call 911 afterwards, but.
And the reason for that, which I'm sure Dr. Peterson can explain this a lot better than I can, you know, an opioid in general is going to have a really long half-life, and Narcan has a very, very short half-life. So you can give it when they wake up, and then once the Narcan wears off. then
I used to keep them at least 2 hours, and I used to give them another dose before they left. With fentanyl now, that might be changed.
Well,
That's a short.
yeah, I think the thing we're seeing with fentanyl, because I was just talking to Joe Trotter, who's our harm reduction coordinator before this meeting, and I think the biggest challenge that we're seeing right now is that we don't have heroin in this community by and large, it's mostly fentanyl. And our population is obviously adapted to fentanyl, but fentanyl, the euphoria from fentanyl is about a third of what it was from heroin, so we have people that are having to use more often to not be physically sick, and so I think that we're, you know, it's
Well,
kind of
now they're
this vicious
mixing,
cycle.
of course, they're mixing it with all kinds of animal trank.
Yeah, that's.
Or it's synthetic fentanyl, which is on the order of multiple orders of magnitude more potent, where a minuscule amount can be given.
Are you getting better data out of the coroner's office?
We've been very fortunate with our coroner, and, you know, now working with Lori is, we've actually met with her a couple times already, and I've talked to her about, working with her to get a quote to the county board for, part of the opiate settlement money to get some testing supplies that she needs for the office. So we're hoping to get, it's not a spectrometer, it's a type of spectrometer, for the county coroner, so that we'll have actual data the same day of if it's suspected overdose, what substances may be involved.
Yeah, because that takes a long time, you know, if they have to send it off and then wait to get it back, and
8 weeks.
wow, that was even longer than I
Because
thought.
there's only 2 labs in the country, the one we use is in Pennsylvania, I believe, and so it takes a long time, and I mean, these are not, and there may be some things that we might get some preliminary data through that testing option. It might not be something that the state's attorney or anybody would accept, but it would give us information that we could get out to the community pretty quickly.
And I don't know what interrupt your flow here, but are you doing sending out street tests for heroin and fentanyl and so?
Yeah,
They have.
Yeah, we do testing
test
strips
now.
for, we have, fentanyl is the biggest one that we're using. Xylazine, we have xylazine testing strips. We haven't seen a lot of xylazine here, but we do have testing strips and also benzodiazepine. Cause it, you know, I'm sorry, I don't know your name. Brent. That's, you know, they.
Is Joe handing those out then with the needles?
Absolutely, absolutely, and with Narcan too. I mean, because it's not, we give a lot of Narcan with the needles, but we're also giving a lot of Narcan to folks that, you know, are family and friends of individuals who are using. So they're doing a lot of door-to-door outreach with that in neighborhoods that have shown up, and because we do get data on where the overdoses have happened in Champaign County, and so we're doing very targeted outreach. I know targeted's not the right word, I'm not supposed to use that anymore. We're doing very data-informed
Curated,
outreach.
we're doing curated outreach.
Curated outreach.
Curated outreach.
So, anyway, that I just wanted to give you an overview of the, you know,
Okay, the other thing we had talked about was the sexually transmitted disease, the doxycycline.
Pep, Doxypep.
Doxypep. Yeah, Dr. Robin is supportive of it. Not a huge fan of it, but is supportive of it, and she does encourage it in situations on that overprescribing here. Doxypep is given to persons who have repeated STI, and it's a way for them to take the medication and get rid of chlamydia on their own without having to come see us. And that's been a part of the PrEP services that some people have taken advantage of.
I think that the literature on that is showing that it's actually pretty effective against syphilis too, which surprised
And
me.
has some-
But
How would
it's
you
not
do that?
so effective against gonorrhea. Yeah.
Well,
You know,
because of course, you know, gonorrhea is starting to become more and more resistant,
Yeah.
which
Yes.
is scary.
Well, it started about 1970 actually.
Yeah. It is scary. It's getting like, you know, come up with a new drug and.
Is there any work done on meth? I started practicing here, and my God, people do meth around here, like a lot.
mhm.
Used to be cocaine, so what we were finding is that two things happened. Was the heroin became fentanyl about 2016, and the cocaine became methamphetamine about 2018. I mean, we did not find, I was not finding cocaine among anybody who thought they were doing it. It was meth.
Yeah, I have to say, going to Chicago, like a lot more cocaine. I would never see meth. Coming out of here, it's rare I would see cocaine. It's like everyone's doing meth. It's very, it's bizarre.
Tastes better.
Last one.
It's the dental problem.
The raw materials, well, yeah, the raw materials are more readily available, and one of them is anhydrous ammonia is a raw material, and they use that on the fields. And I only know this because my dad, he's retired now, but he worked for FS, and they put anhydrous ammonia on the fields, and they had become more and more crafty about how they distributed it, because you would usually just hook up two big giant white tanks of anhydrous ammonia. You drag them out into the field and then leave them there for the farmer. Well, then they're sitting out in the middle of nowhere. So making sure that the way of getting it out or opening that tank was complicated enough that you could just view it, but the farmers still could. Was complicated, or changing how you drive it out to the field.
Well, and what we found is it really wasn't being manufactured in the barn or the church basement, by the way. It's now being distributed by the cartel.
Yeah.
And it's better, cheaper, but probably, if anything, not as much lithium mixed with it, but it's part of the chain now, very much part of the chain. Yeah, it really is dangerous to be out there these days. And I'm surprised we haven't had an increase in death rather than something of a tampering down. 20,000 fewer deaths last year than the year before. I'm surprised. It has something to do with a decent economy, which I think is going to change.
It's, yeah, it's, anytime that goes
Yeah.
south, all kinds of things go south, unfortunately.
It's another thing to track also is just not only mortality but morbidity. So that's what I'll see is like people suddenly cardiac arrest or having strokes and stuff like that. Well, I'm a neurologist, so that's like
No.
just gonna be right. You know, maybe they seize, I don't know, you know, but yeah,
Are they mostly shooting meth around here? I mean, I know it was like a snortable, when it was first here, it was like snortable more.
I mean, we literally just surveyed our clients on what substances they're using and how, and not surprisingly, most of our folks are gonna use injection because that's what we're doing, but methamphetamine and fentanyl and meth were the primary drugs in the area, and this is the survey that we did right at the end of last year.
so people are injecting the meth?
Sure.
Oh, yeah, that's the,
If you're
yeah.
injecting fentanyl, yeah, injecting that too.
Yeah, no, it's actually, no, it's like it's important, because I would always think like, okay, that's good for me to know.
Well, they're mixing the fentanyl and the methamphetamine into street marijuana. It,
Thank you very much, Candy. Are there any other
Yes.
questions for Candy?
Very good, thank you.
thank you. It's a good program, you're up against a big problem.
I know, I feel like this is like a big topic of like what services are gonna be affected by lack of federal funding.
It's scary, because that's what is so irksome about it, is that, you know, the HIV, Candy and I both started back when there was like nothing, and, you know, getting this far in 30 years to see that we're actually to a point where, you know, we can prevent it with a pill or a shot, and you can, and a program, and you can, you know, virally suppress people, and we're getting to zero, and then they're like, no, enough of this, you know, that kind of stuff, just arbitrary, it's cruelty is what it is. It has to do with, you know, traditional target populations, that's all it is, and it's.
Well, something of the irony is that the president is using fentanyl importation as a reason for the embargoes.
Which is just idiotic, because if you look at any of the stats, speaking of tertiary syphilis.
It would explain a lot.
Yeah, but that's, yeah, it has nothing, there are some coming over, but even if you look at the stats for the Mexican border, it's coming over with Americans, and it's worth bringing it over. You know, they throw these narratives, but when people don't bother to look up the
The only way that's going to stop is if the demand stops.
How
I
long have
don't
we
care how
got
much
these
you
things
pick up
going?
there. If you pick up more and more is being going across. You pick up your street dealer, he's replaced in 2 days.
Yeah, right. It is a demand, and, you know, we're getting ready to see, I think, unless things change, record demand.
Yeah,
probably.
Because just, you can put the maps together and you can show how the economy does and how drug use, they just kind of, economy goes down, drug use goes up, all kinds of things go up, morbidity and mortality.
Alcohol showed that during COVID. Alcohol was,
Yeah.
and we're still seeing the results of that.
Thank you very much, Candy, and thank you, Marie, for that conversation, discussion. Our next item is update on the teen pregnancy prevention program.
And since I already looked at your thing, I'm going to
Okay, you
say a
can
little
get
of that, when we're back.
Okay, my name's Whitney. I'm the Director of Wellness and Health Promotion. So one of our programs is comprehensive sex ed, teen pregnancy prevention, if you will. This body has given us funding for the last handful of years to do sex ed in the county. We have a grant from the Illinois Department of Human Services that allows us to do it in Champaign-Urbana. That grant requires us to go into schools that are at least 40% minority, so some of our county schools don't meet that requirement. So that's what we use your money for. We appreciate it. So since I saw you last in, I think it was October that I saw you last, we finished a whole school. So this is the infographic for Fisher Junior High. We were with the 8th grade students in October and November 2024. So this is just a small infographic about some of the highlights, learning points that the students shared with us. So you can look at that at your leisure, and there's some festive quotes from the students, so that was great. We are fully staffed now. In January, we hired 2 new health educators, so we're a fully staffed team for our health education folks, so we'll be able to go out and do some more programming. We do have Fisher High School, the 9th grade class, on our schedule for the spring semester, and then we're reaching out to Thomas Moreau, Ludlow, Gifford, and Prairie View, Ogden, all feeder schools for Rancho Township High School. I think those are the only ones. And then we're also at Ader Junior High in Rantoul, and we're with the 8th grade students there. So we've got a pretty big net of teen pregnancy and STI prevention in Champaign-Urbana and in the county. That's our spiel. Any questions? Fantastic.
Great job, Whitney. Thank you.
Wow. I'll report.
Efficient.
Last
Yeah.
2 minutes.
He's got that speech name.
Yeah, the only thing we have is, but if we talk about the budget, is how to keep this program sustained without having to use our carryover.
We do have plans to ask the county schools if they would be able to put more funding for it. Now, in the current state of affairs, that's not the best ask with everything going on. So I'm gonna tiptoe through that, see how it goes.
Yeah, I think when we get to the June meeting and then of course following into the August meeting, likely a longer conversation because we'll need to look at budget and make determinations on funding from, see where our fund balance is at that time, because we've been predominantly utilizing the fund balance for both the Promise Healthcare program for bringing in the dentist and doing marketing for that, and then as well as this program with doing the education in the schools, thinking about, giving some time to make some of those decisions, and we don't know what else may come about that might, be additional needs, and, we've also given some funds for the nursing home project. So, if I would say this whole body, if people are thinking of other ideas, it's important maybe we start now because some of those take time to develop, and at the same time saying, okay, within a certain time frame, we're looking that funding might, be coming off, and that might give you more leverage to say, hey, you really like this and you really want this funding in the next year or two, maybe going away. So I don't know, I think it's probably a bigger conversation, but it'd be good to give people some time. We don't really want to hold things out in an immediacy, but maybe having that conversation about how best to utilize that. As far as I understand now, we can have Mandy maybe come to the next meeting perhaps in June, but give us an idea of where the fund balance currently sits. Now, the fund balance for those of you is, we have funds that originally we talked about having at least a quarter of funds available to continue to provide all of the services to all of the programs that we currently provide services are. So 25% of our, reserves should be in the fund balance, or, what we have available to continue to run programming. That said, we can't always rely on, as we did with COVID, that grants will come in if there's another epidemic. And so it can be very easy, if there's $400,000 there, if we just go back and look at COVID, $400,000 would have been used very quickly. It went by very fast. Now we had, what was it, one grant was $2 million?
Yeah, we have a lot of funding shockingly coming in, but we also did not have to wait. We did not have to wait for grants. We bought, when we very first heard about the Pfizer vaccine, we went out and bought the super freezer. So we were ready, and that was one of the first things that they asked, do you have to, they surveyed us to see who have availability to get the vaccine in.
So we didn't have to
Now we
dip
just
into
have
our
super
reserves.
cold ice cream bars back there.
It's continually to be used. It's COVID is the gift that keeps on giving. So, but anyway, we didn't have to go in our reserves for that, but those are things that we have to keep in mind because we don't know when we might be the next Missouri with TB, or we might be, measles, whatever might happen, we might have to dip into those. So that's always something we have to keep in mind, but these are, exceptional programs. And so I think, we come up with a plan so we can give adequate, communication, to people to make a plan for what might be the next thing. But that's a very good point, Dr. Peterson. I do.
Could y'all look at pre-test scores on these questions?
They're really good. Yeah. That's good.
Scary. Yeah.
They're so
Very
good
good
stuff in here,
program.
and it goes well with Candy's presentation.
Yeah, it does. No, I just meant the pre-test scores. I was like, good lord. I mean, 14%. I mean, that's, what?
Okay, our next items are 7 and 8. These are two reports. So we looked at that Atlas program. One of the absolutely outstanding things about Champaign County is that monthly reports are placed online for anyone to look at, from what Candy provided on the teen and adult services to what Whitney's doing. All of that information is available. So that's what these two items are, is saying we just have to basically give our approval to have that information there. It is there every month, so we're kind of like after the fact every month approving this, but that's what those two items are. So I just need a motion to go ahead and approve the CUPHD reportable diseases and performance management reports to be placed on the website. So I'll open it up for that motion.
I'll move.
Moved by Dr. Peterson, second by Dr. Sander.
Now, looking at
Any
that, is
discussion?
Julie, did I read it correctly? No gonorrhea or chlamydia?
That can't be right. Can
Yeah.
Yeah.
you? There was no gonorrhea or chlamydia on the report? I don't, there was none on there?
No way, the university doesn't have.
Right.
It's the keyword is report.
Yeah.
If that's the case, Candy, you're doing fantastic.
Okay, so that's an interesting question. Does McKinley report you guys? Because they do a lot of testing as well.
They do report to the state, and we work with them as well to make sure that their folks are getting treated.
Yeah.
And we interact with them mostly around TB, but, because they do a pretty good job with the STI stuff, but, not that they don't do a good job with TB, they just need more help. Yeah, that's a disease that needs more assistance. Yeah, we work closely with them. Every agency in town that does any STI testing that goes to any lab gets reported to us eventually. We actually worked with Carl in the last year for them to report their syphilis positive cases directly to us and not go through the state system, because the state system takes 2 or 3 months for them to get back to us sometimes.
Yeah.
And it depends on their staffing. So we get their reports when y'all get them, which is awesome.
Any other questions on those reports? Hearing none, all those in favor?
Aye.
Anyone opposed or any abstentions? So before we get to old business, I know we've had people in the audience and other people and people that needed to leave. So we do have new members. So it might be good, I know a couple people had to leave early and I was trying to get us to this point, but perhaps it might be good for us just to go around and introduce who we are so that everyone knows that, and my apologies for all the different speakers that we've had today to not get to this sooner. So I am the current chair of the group and have been for some time, and I'm Krista Jones, and I'm the director of the University of Illinois College of Nursing, and have been a part of the Champaign-Urbana Public Health District since back in 1994 when I worked here previously with Julie and the group, and then left to go into working at Carl and working for the university, but still maintain a lot of relationships with the individuals here. That's things are all right.
I'm Will Sander. I'm an assistant professor of preventive medicine and public health at the College of Veterinary Medicine, and I also teach wildlife medicine there too. And I direct, so we have a DVM PhD degree program there. And I'm a new member too. My first meeting was last meeting.
Oh, nice. Yeah. I'm sorry I missed the last meeting.
Oh, no, we completely understand. We got short notice.
I'm Gregory Sackman, Medical Director of Children's Services at Carl, and one of the hospital pediatricians, and I also run our child abuse and neglect through
still do cigarettes.
Julie Pride, I'm the administrator here for health.
John Peterson, retired but still active. I have been working with public health, been on this board for a long time, but really got introduced to public health when all this started. Needle exchange and the like. Attempted to set up a methadone clinic, ran into the DEA's opposition. Ran into a lot of opposition in addiction medicine. So I worked ER was my day job, but I did addiction medicine since 2002. I staffed a methadone clinic for 10 years. And then I set up my own youth and orphan clinic until a year and a half ago. Currently active with state societies in addiction medicine and policy.
That's great. Hi, I'm Neil Sharma. I'm a neurologist at OFC, person at Carl. I just joined the team from November, July,
Welcome.
Commissioner Bennett. I'm Lindy Goodland. Got to be the happiest retired veterinarian in all of Illinois.
You saw bird flu coming.
So this is my second term leading the board. It's very informative, great staff, and great board members in front of the board. So welcome, Champaign.
And Amy Roberts, she's taking notes. She works in HR, but she is periodically stuck taking notes and the various minutes of the meetings. And then you met staff back there.
Dave Thies have had to leave, the board for like 3 terms or something. An active
4 or 5.
attorney. And he's the current vice president.
And then Beth, that was next to it, is, she just got on last meeting as well. And she is the county board liaison. So that's why she's asking all those questions. She takes it back to the county board so that we can hopefully get things passed there as well.
It's a pleasure to meet you guys. I'm very excited.
Well, we're excited that it's great to have another neurologist in town.
I'm just excited that should I like fall out of my chair and have some.
Yeah, I got you. I got you.
You
You don't have to rely on
like,
pediatrician.
we're good to go in here.
I did pediatric neurology for a long time with Piketty and Dr. Ferris and Dr. Kennedy, and yeah, we're missing a lot of those things for quite some time. So very nice to have you in the community. Okay, that takes us.
Yeah, now I'm happy to do this now, but given the time, would you rather delay this for the next meeting? Up to you. I'm happy to do it.
It's not till June. Is that good?
That's okay.
It's June
That'd be
5th,
all
what do
right.
you have to
We're-
provide?
Right. The only thing I would add is that's fine. I would like to talk with you because we've had a meeting with Senator Faraci, who's trying to pull together some stakeholders, and I would like, both cities have agreed to participate. Somebody from Congressman Kuczynski's office is going to participate, and I think it would be nice if you would be willing, as the chair of the county board of health, to participate as well. Just so.
Well, did you hear I spoke yesterday? I spoke yesterday at something that they put on, and Ackley was there.
Oh, yeah.
Luckily, Joan Dixon was there.
Yes, she was there on behalf of us.
Yeah,
Right.
she popped right up out of that.
She said she did.
So,
And I'm happy to do it today, but I just thought maybe everybody would like to know.
Sure. No problem. Is that everybody get that? We'll put it on for the June meeting. So June 10th, our next item then would be public participation on non-agenda items. Do we have any public participation on non-agenda items? They're all looking like they want to get in. I think those eyes are for you guys. So our next meeting will be June 10th at 5 p.m. Here, and I will entertain a motion then to adjourn.
So moved.
Do I have a second? Moved and seconded. Any discussion on adjournment? Hearing none, all those in favor? Anyone opposed or any abstentions? Thank you all so much. See you on
So
June
Julie,
10th.
fix that clock because this has been a long meeting.
yeah, we do that so you'll look at it.